Good afternoon. This is about a 16-year-old boy who's doing his 12th standard from Vellore. He presented to OPD with history of throat pain and fever for one day with painful swallowing. He did not have any history of recent travel, and his mother had passed away 12 years ago. On general examination, he was comfortable, he was afebrile, his pulse rate was 88 beats per minute, it was regular. His blood pressure was 100 by 70 millimeters of mercury, and his respiratory rate was 16 breaths per minute. His oral cavity showed a congested throat with grade 3 enlargement of tonsils, and he had bilateral multiple enlarged tender jugular digastric nodes in level 2. On systemic examination, in CVS examination, his apex was not shifted. S1 and S2 were normal in intensity and character, and there were no murmurs or added sounds. His respiratory examination showed a trachea that was midline with bilateral normal vesicular breath sounds, no adventitious sounds. On abdominal examination, his liver and spleen were not palpable. There was no shifting dullness. CNS examination was normal. This is a 16-year-old boy who presented with the syndrome of acute pharyngitis or tonsillitis. So we had considered a respiratory viral infection, a group A streptococcus or other bacteria which can cause an acute pharyngitis or tonsillitis, like a group B group B or group C streptococcus or a Corynebacterium Diphtheria. We also considered infectious mononucleosis because he had lymphadenopathy, or an acute HIV infection which was presenting like a URI. So these were the investigations that were done. He had elevated counts of 14,900 with neutrophils of 74%, lymphocytes of 18%, and monocytes of 10%. His hemoglobin was 14.7. His platelet count is 2,86,000. His malarial smears were negative. HIV ELISA was negative. And his throat swab smear and culture showed this. This was the gram stain that was done in our lab, that is showing gram-positive bacilli, which are arranged in V-shaped palisades or the Chinese letter pattern, and when cultured in the low-fluorescence medium showed creamy white colonies. And the low-fluorescence medium was subcultured and special stains were done. And this is the Albert stain, which is showing green bacilli with brown metachromatic granules, and Ponders stain showing blue bacilli with pink metachromatic granules. So all this pointed towards Corynebacterium diphtheriae, and his PCR was positive for Corynebacterium diphtheriae. And his toxin assay, which was also done by PCR, was negative. His ECG did not show any ST or T wave changes. His QTC was normal. The bedside echo was also normal, and his cardiac enzymes were normal. So, Corynebacterium diphtheria is a rare infection, and this was the first that our lab had seen this year. It is caused by a gram-positive bacteria, and these are the clinical syndromes that are described. They can present like how our patient presented with a respiratory disease with sore throat, fever, lymphadenopathy, or it can be a cutaneous disease where patients can present with chronic non-healing ulcers, shallow sores with a grayish-white membrane, or they can be in an asymptomatic carrier state. And transmission is through respiratory droplets or close contact with skin lesions. Humans are the only reservoir, so our patient could have only gotten it from another human who was infected or who was an asymptomatic carrier. So this is a classically described pseudomembrane, which is a leathery grayish-white membrane which is seen over the tonsils. This is only produced by the toxigenic strains, where this toxin that is produced by the bacteria induces the formation of this coalescing pseudomembrane, which is composed of necrotic fibrin, WBCs, RBCs, epithelial cells, and the organism itself. And this is an indication for administration of antitoxin. However, our patient did not have the presence of a pseudomembrane. He only had congestion, hyperemia, enlarged tonsils, and lymphadenopathy. So our patient did not have a pseudomembrane because and his toxin assay was also negative, so he was infected with a non-toxigenic strain. In toxin-producing stains, there's presence of this exotoxin because of the presence of this tox gene, where it helps in producing this exotoxin. And unvaccinated individuals are are all susceptible to getting infection from these toxigenic strains. However, non-toxigenic strains can also infect people who have completed their age-appropriate vaccination. Toxigenic strains produce a more severe disease. Non-toxigenic strains produce a less severe disease. Pseudomembrane is present in toxigenic strain infection, and there's no pseudomembrane seen in non-toxigenic strain infection like in our patient. When there's a suspicion of infection with a toxigenic strain, you treat with antibiotics, and prompt administration of antitoxin is also given. However, in patients who have infection with non-toxigenic strains, only antibiotics are indicated. The described complications in patients with infection of toxigenic strains are myocarditis, neurological toxicity. There can be local neuropathy, that is impaired gag reflex, and cranial neuropathy or peripheral neuropathy. Non-toxigenic strains can also have complications like endocarditis, mycotic aneurysms, osteomyelitis, and septic arthritis. So this is the Elek test, which is done to differentiate between a toxin-producing and non-toxin-producing strain of Corynebacterium. There's a strip which contains the antitoxin, which is embedded into the agar, and a control and a test Corynebacterium diphtheria inoculated into the same, along with the test. There are these 45-degree fine Preston lines that are seen that grow across the test. If they are present, then they are toxin-producing strains, and if they are absent, as it is in the absent control, then they are not. In our lab, the Elek test was not done. We did a PCR-based toxin assay. Who are all at risk for diphtheria? Diphtheria is primarily an infection among children. Up to 60% of adults are susceptible because of waning vaccine-induced immunity, because of failure to receive the recommended booster immunization. Close contacts of unvaccinated individuals are also at risk, and inadequately vaccinated travelers into endemic areas like Southeast Asian countries are also at risk. Up-to-date vaccination status in an adult or in a child does not alter the risk of non-toxigenic strain infection. Waning of vaccine-induced immunity in adults causes all adults to be susceptible to both toxigenic and non-toxigenic strains. So this is the recommended vaccination regime in children according to the IAP schedule, where DTP vaccine is given as a primary vaccination at 6, 10, and 14 weeks. The first booster is given between 15 to 18 months, and the second booster is given between 4 to 6 years. And a Tdap vaccine is given between 11 to 12 years. And following that, every 10 years, they are supposed to get a booster vaccine of TD for all adults who have completed prior immunization. Immunity does not prevent carriage, and up to 5% of the population can be carriers in endemic areas. Vaccination also does not protect against non-toxigenic strains. This is because the active ingredient in vaccines is the diphtheria toxoid, and it's present in different concentrations in the various vaccines. The DTaP, the DT, and the Tdap are used for primary immunization among adults, so they have a higher concentration, which is measured in limits of flocculation. The TD is the vaccine that is recommended for adults every 10 years. That has a low concentration of the diphtheria toxoid too. In our patient, we had admitted him in isolation ward, and respiratory droplet isolation was maintained, and he was treated with oral antibiotics, tab erythromycin 500 mg every 6th hourly for 14 days. Today is day 9 of antibiotics. After starting antibiotics, within 48 hours, he had resolution of all symptoms. He remained afebrile while he was in the ward. His throat congestion resolved. He was monitored for complications, and he did not have any. Antitoxin was not administered because we had clinically suspected a non-toxigenic strain infection. And persons with close contact were identified, and his relatives were given TD vaccination and started on antimicrobial prophylaxis, and throat swabs were also done. The presence of a pseudomembrane indicates that the infection, that the Corynebacterium strain is toxin producing. It's a surrogate for toxin production. And if there is no pseudomembrane present, we should still suspect Corynebacterium infection, because it can be a non-toxigenic strain that has infected the person. And all adults are susceptible to diphtheria infection because of waning vaccine immunity. So a booster dose of TD vaccine is recommended every 10 years for adults. vaccination does not confer protection against non-toxigenic diphtheria infection.
Any comments, questions?
So what you're saying is that despite vaccination, there can be diphtheria transmission.
Yes.
That's right. So
Yes, sir.
what is this patient's primary utilization?
Yes, his mother had passed away 12 years ago when he was 5 years old. We could not get his vaccination schedule, his immunization card, but historically, he was a staff-dependent child, so historically, his father said that he was age-appropriately vaccinated, but he still developed the infection.
So last year, there were outbreaks of diphtheria, right? And what was the cause of that? It was in Kerala and North Kerala, there were outbreaks of diphtheria. And in this area also we had outbreak of diphtheria. What was the reason for that? Was it the waning immunity or was it gaps in the primary immunization?
It was because of gaps in the primary immunization, because it was predominantly a Muslim group of people who did not believe in vaccination.
In North Kerala, but in Tamil Nadu also, this Vellore district also we had, from Chittoor also we had cases. So, see, in the last 50 years, one of the major changes that has happened all across South India in Vellore was the eradication of vaccine preventable diseases. So, when I was young, 16, I got pertussis. And in that 70s period, 80s period, diphtheria, measles, and mumps, they disappeared. And now we are having a new, I don't know if you call it resurgence, but outbreaks of diphtheria that we are seeing. So it wasn't seen for 20 years. So till about last year or the previous year, the last case of diphtheria that I saw was in my registrarship, which was 1993. So that there was a whole gap, and then it seems to be coming back. And the question is, why? So why do patients with diphtheria die? What is the complication which causes? Can you hear me?
Myocarditis.
Yeah. What else?
Neurological.
You didn't describe the neurological. What happens? What is the problems that people get? Palatal palsy. That's a clue to the diagnosis. So there was peripheral neuropathy. So these are the two things which actually kill. And one more thing happens because of the pseudomembrane. So the pseudomembrane affects the epiglottis, can actually cause stridor. So you can get acute stridor, which requires tracheostomy. You get palatal palsy, and patients can die of myocarditis. So one issue that came up recently in relation to the outbreak was antitoxin. And this patient, it was not required. But is it available in our pharmacy?